Welcome to the Four Eyes podcast, brought to you by Young OD Connect. We give you a clear view into the new grad optometry world across Canada and the US. We are your hosts. I'm Dr. Bilkhu.
And I'm Dr. Deepan Kaur.
And today we're going to talk about myopia.
From a different lens a little bit.
Yes.
Right? What does that mean, a different lens? So, yeah, I think when we think about myopia management, what are the first things we think about, right? Like the minus lenses, atropine, ortho-K. But since Dr. Amrit Bilkhu is a specialist in BV, I wanted to kind of pick her brain about thinking about myopia management from a different perspective, basically from her perspective, and how to kind of think of treatments differently. Instead of always thinking of the typical, minus lenses, atropine, ortho-K, those kind of things, but more so, from a BV perspective.
Basically, Deepan didn't want to do a lot of work for this podcast. And she said, oh, we can just interview you. Bring your material. And I said, okay, sure.
But it's interesting though, because
I know
you've posted a couple things about it on your Instagram.
Yep.
If you guys haven't seen some of this information, I highly recommend checking it out because honestly, it does work for primary care eye doctors. Like I'm a primary care eye doctor. I'm not a specialist in myopia management. I don't specialize in BV, but there's little tidbits of information she has on her Instagram that I think we can consider and take into account when we're thinking about myopia management treatments.
So you know what? We'll just dive into it because I thought we would maybe start off with how was your week? How's everything going?
No, we don't got time for that.
No, we don't have time. There's so much to talk about.
Exactly. Yeah.
What I will say is, first of all, thank you to people who did watch those, case stories on Instagram and have shared comments and are really interested in learning more. I'm not the myopia guru. I'm literally learning from other BV docs, other docs in VT, behavioral optometry. I keep saying it because I feel it's so true. Behavioral optometry is like Narnia. Like you have to find the wardrobe, open the doors, go through the tunnel, and then you get into this whole nother universe. And it's hard to
I'm halfway through that door, okay?
No, we locked you out. We don't want you in. We don't want you.
I'm waving to you halfway through the door. I'm like, I'm almost there, Amber.
That's true. Cause I feel like I've definitely encouraged Deepan, every time we do this podcast, we get together and then obviously we talk a lot behind the scenes. And I've definitely convinced Deepan of a lot of behavioral concepts too. So it's cool to see that half the time you're practicing the same way I'm practicing now and you're getting the same results, which is really nice. I was going to say, I find that myopia in general is starting to become very similar to health conditions that are just treated, in the Western way, in the Western world.
Yeah.
I'm so into understanding and appreciating Western medicine, but then also appreciating kind of Eastern medicine to just know that everything is connected in the body. Obviously, there's always a root cause to a problem where the body is, out of balance, it's out of sync. And then what can we do to bring that body back into balance? And then eventually, your symptoms will resolve and things like that, right? Or at least get better. And myopia.
And I'm a huge believer in that too, though. I really do like natural medicine where you don't have to always consider prescription medications. If there's other ways you can heal your body naturally, I think that's honestly my first go-to versus just constant treatment of outside or external things.
And ask your patients that. Every patient is like, oh, if there's a natural way to do something and I know it'll take time, I want to try that first. I want to try something natural. I feel like the only people who are not willing to try natural remedies are the docs themselves, right?
Yeah, that's true. And this comes with a caveat. We're not talking about corneal ulcers and we're like, we're going to treat this naturally.
No.
Of course not.
That.
We're not talking about that.
Once you start understanding that the body is not just functioning the way it's supposed to, if you can do other things to get that body functioning again in a normal way, half of these symptoms would resolve. And
Mhm.
so that's how I see myopia. Myopia is definitely, an issue. It needs to be addressed, and we are, as a profession, doing a great job addressing it,
Yeah.
right? With all the treatment options we have. But in my head, every treatment option that's thrown out there right now is kind of like throwing medicine at a condition and not giving it like herbal tea. Like
Yeah.
we're not giving it the herbal tea and the acupuncture
Yeah.
like we should. And so I think it would be really great to start educating primary care docs and just optometry in general that you can still effectively treat myopia naturally with regular glasses, regular lenses, regular contacts, vision therapy, or just educating the patient how to change their behaviors and not
Yeah.
just say, go play outside more.
Yeah.
No, that is the dumbest recommendation. Like, because it's not explaining to anyone, why do I have to go outside more?
Mhm.
What is the difference between me being inside versus outside? And we all think it's just to look far.
Mhm.
That's not the point.
Mhm.
When we're outside, we're often not doing a near task that has a
Yeah.
high visual demand and a high
Yeah.
cognitive demand.
Yeah.
Like, that's the difference. And so when we start explaining that to patients, like, it might change their perception on their behaviors throughout the day and like what they're doing. Yeah. I'll take a break
Especially
there.
with kids on like screens nowadays. I think we're all used to this, especially with kids when they come in, most of the parents are like, "Oh yeah, their screen time is almost like 5 to 6 hours a day." And this is like
Mhm.
even after school. And these
Yeah.
kids can range from 5 years old to like 15 years old.
Yeah. Yeah.
That is heavy use of screen
Mhm.
time, right? So I think, yes, talking about these different behavioral changes
Yeah.
and yeah, not just saying, oh, just go outside and,
Mhm.
play. There has to be a little bit of why to that to explain, okay, the reason why we're saying this is exactly what you said, Amrit. Like there's
Yeah.
less demand on near tasks. There's less of that work you have to do when you're
Mhm.
outside. But even if when you're looking at something up close, yeah, there's not that as much focus when you're doing that outside, right?
Yeah.
So
No.
it just makes sense.
Adding to that, I think this is what we are missing in the more public, information about how myopia even comes about. There's different theories, right, as to how myopia comes about and how axial elongation happens and all this stuff. And
Mhm,
in more of the behavioral world, we emphasize the near stress theory. And so I think that
mhm.
is something that in primary care optometry, general optometry, near stress is a real thing, but it's not being emphasized as one of the, main causes of
Mhm.
myopia. And so near stress is basically, just to kind of shorten this down. There's obviously a lot of textbooks from the OEP website that people can buy if they want to read more, but near stress is basically saying our bodies naturally are not meant to focus on things up close, right? We are meant to hunt, we are meant to live outside and roam the world and whatever. So, obviously, as our lives changed and reading and writing and literacy, and education became a thing, our eyes are now focusing on something up close for longer periods of time.
Mhm.
And so our eyes are not comfortable with that. And they're
Yes.
not comfortable with that for a few things. One, we have to accommodate more, but now there's a cognitive demand. We have to now understand that paragraph, read it, comprehend it. We're learning something new. That takes stress, anyways. Think about how stressed you are learning a new activity, right?
Yes.
So
Yeah.
that increases a stress response. Stress is
Right.
related to your sympathetic nervous system. So when your
Mm.
sympathetic nervous system turns on, what do you do in fight or flight mode? Your pupils dilate and your accommodation shuts down.
Mm.
So what do you do if you're staring at this paragraph stressed out and your accommodation shuts off? Well, you activate its sibling, your convergence, and you try to converge to stimulate accommodation again. You're basically fighting the
Yeah.
sympathetic nervous system because you're saying, I have to read this, I have to get this done, right? this whole mismatch between the accommodative system, the convergence, and all this stress that you're accumulating, there's a lot more details to this model. I'm making it very generalized, but your eyes are basically fighting. Your body is fighting against what it wants to do because what it wants to do is run away. It wants
Right.
to stop reading. It's uncomfortable. But we live in this world where kids have to start learning ABCs at the age of like 3. And then
Yeah.
they go to school full time Monday to Friday for like 6 hours a day. We're
Yeah.
forcing them to sit at desks to learn new concepts instead of being outside hunting and learning new concepts, right?
Yeah.
Literally, like, I mean,
I know. We're not
some of them are
evolved to
probably
look.
still hunters at this point. Boys are crazy.
Yeah.
5-year-old
No,
boys?
but you're right.
Wow.
We're not evolved to be
No.
looking up close all the
N-
time. And it's just
Literally.
something our body now is trying to learn
Yeah.
to adapt to.
Yeah.
Mhm.
So that's where I think like this concept of, oh, go outside more near work causes myopia. Yes, but no. Near work causes physical stress.
Mhm.
And then your body adapts to the stress. It's either going to stop reading and avoid near work, or it's going to adapt by becoming myopic. So myopia is in the BV world a symptom.
Mhm.
It's not the actual problem. You know, your
Mm.
body is changing, causing your eyes to readjust its focus so that you can overcome the stress and continue on and read for 3 hours at a time.
Right.
That's where the myopia kicks in. And it's not only myopia that happens with stress. You get other things, which is where this myopia personality has kind of come up from. It's not really a
Oh.
personality, but when we're stressed, we get tighter neck muscles and shoulder muscles. We have just overall more tense posture. Our
Mhm.
breathing shortens. We start to hunch over because we're, bending closer and closer to the work. Like everything becomes, part of who we are, like as a person.
Yeah.
And
You're
so
saying like every -10 prescription person is
is
like that
almost the
hunched
exact same.
over, like never sees the light of day. They're just like, what do you want? I need to go back to my books.
Yes.
Like
And
it's
now,
just like,
obviously, it's not 100% true, but I mean, you get the general idea, right? I mean,
yeah.
I think that's what we're missing in educating optometrists and then educating our patients. Like, myopia is not something that, oh, you know what, you're 3 years old and boop, it just showed up. No, it
Yeah.
it didn't. Congenital myopia is going to come like out the womb, right?
Yeah.
Obviously, from other things like prematurity, degenerative myopia. Any myopia that is triggered from toddler years and onwards, it is triggered from the stress that they are experiencing from their environment, whatever the stress is being caused by. And so that's why, I do promote the idea that, yeah, myopia can be reversed in some people because when the myopia is really small, or, it's pretty mild, if we start educating the patients not only on the lens options that we have, like whether it's
Mhm.
contacts or, glasses, but if we start to really educate them on changing their habits and their behaviors and their breathing and their stress levels, you can really work towards like reversing their prescription. And I have so many kids that I have lowered their myopia or reversed their myopia completely after 1 to 2 years of all of that, of lens therapy and, educating the patient and the parents on why they should change that behavior. Because once the
Mhm.
parents know why,
Yeah.
that they get it, and then they start to really implement that, on a daily basis. Sorry, last thing, when you mention, like, lots of screen time, it's not only the screens. It
Mhm.
is anything they are staring at up close for long periods of time.
Oh yeah. Even for the avid readers, the drawers, the like any
Yes, the
focused work up
Skechers.
close, the
Yes,
sketchers.
everything.
Yes. Yeah. I
Yeah.
was gonna ask you, what if you had a child coming in, but their parents were both like -8 or above, and there's like that genetic component that can potentially um cause their
Yeah.
child to be more
Yeah,
myopic.
myopic. So, that's a really interesting one that I've kind of thought about after reading a few things too. Same thing again. I find that, first of all, if you say, both parents are myopic, you're at a high risk of being myopic. I mean, if both parents are diabetic, you're at a high risk of being diabetic. Does that mean you'll get diabetes? Absolutely not,
Mhm.
because you as a person can still grow in a different way, have a different environmental exposure, whatever, work on your nutrition. There's a lot of people out there who will avoid the, impending health issues that they're going to get from their parents. So myopia, I think is the exact same concept. Just because parents have myopia, that does not mean you'll get myopia, but you are pretty much almost a mirror copy of your parents,
Mhm.
right? In terms of personality and
Mhm.
behavior. And so when you have that anxious mom coming in who talks so fast and has so many questions and like wants to like really freaks out, I bet all the money I have that that child also
Mhm.
freaks out, panics, has anxiety, has high stress because we end up being very similar to what our parents are like. And because
Mhm.
that's all we know and that's how we grow. I don't know if it's just genetics playing a role or if it's the fact that they're learning behaviors from their parents and then adopting those personality traits and behaviors that led their parents to become myopic,
Yeah.
and then at 3 years old and 4 years old, they're becoming myopic.
Yeah.
Like that, like, honestly, I think we're not thinking deep enough as to why, myopia starts in young kids. Now, it's different if, like, I've had a 3-year-old with -12.
Yeah.
In those situations, you're really like, okay, we need to dilate, we need to get some genetic
Yeah.
testing
Yeah.
done. But if you got that 3-year-old with a -1, -2, I mean, yeah, it's
Well, that was gonna
probably.
be my next question. Like, what is you were, like, talking about mild myopia. What is considered mild? Like, to me, like, when I'm thinking of, like, mild myopia, if I have a six-year-old that comes in and they're under, like, a -1, yeah,
Mhm.
I won't prescribe
Yeah,
like,
same.
minus lenses, but if
Yeah,
they're, like, a -2, then I'm like, "Ooh, I don't
yeah,
know, like, this might be." Now we gotta start thinking about those myopia management treatments that we
yeah,
all are aware of.
yeah.
That's what so what is to you, what is, like so mild myopia is, like, what's under -3? Basically -3 and under.
No, no, no. I agree with you actually. So, I mean, I guess in terms of what I prescribe or what I treat, right? So,
Mhm,
I guess I can categorize it that way. So, myopia where I would not correct their distance RX at all is, yeah, within like under -1 or -1.25.
mhm,
Um but again, depending on the who it is, what their age is, and what their situation is, right? Anything higher than like a -150 in older kids, I find that okay, like, if you need a little bit to see a bit better for far, I'm going to give you something. Am I going to give
mm,
-150? 99% of the time, absolutely not.
mhm.
And I think this is another thing that, we're not teaching practitioners is, when it comes to prescribing for myopia, it's really helpful to prescribe for what their visual demands are on a daily basis. Because
Yeah,
yeah, I think we talked about this in our refraction episode a little bit
yeah.
because we, like, don't over minus and don't prescribe 20/20 all the time
Because
with.
then a lot of people will think like what you're saying, they're undercorrecting. And that's one
Yes.
of the issues that can cause myopia to become worse over time, right? So,
Yes, and I'll
yeah.
tell you why I think that happens. There's
Okay.
we guys, we have no outline for this episode, so I feel like
We're just
our
gonna hop all over the
where
place,
it's
but
gonna
that's
be so
okay.
scattered. It's gonna be so scattered, and that annoys me because I'm really trying to find a way to present this in like a CE lecture that's more
Well, this will be
organized.
helpful. You could just
Yeah, just
present it
listen
this
to
way. I'll
this.
just hop over here a little bit, hop over here.
I'll
Oh,
be
missed
back
that
here.
point over here. Let me sprinkle a little bit of knowledge.
Literally,
What is your response to that?
I feel like I'm in a presidential debate.
No, I'm just saying like from
No, I love it,
from
I love it. Um, there's another concept out there that I highly recommend people to read. I'm gonna put some books, like, in the links below, and then you
Mhm,
guys can always read these books. There's a very short and easy read about how society and optometrists have also probably triggered a lot of myopia progression in patients. Like,
mhm,
we are the reason for that.
Mhm.
And so the first reason why myopia will progress is number one, you're not educating or the patient is not understanding how to change their behaviors, right?
Mhm.
Like literally you can't just say go outside. You need to really get deep down and explain why these behaviors need to change. So yeah, even if you undercorrect, you overcorrect, you don't correct, if they're not going to change their habits, they're going to progress, right?
Speaking of habits, sorry, I just wanted
Mhm.
to add a couple things. You mentioned a couple things in your posts before, with the habits is also holding near material about, an arm's length away with
Yeah,
proper
Harmon's
lighting.
distance or arm's
Yeah,
length, good
yeah,
lighting,
yeah,
taking frequent visual breaks from near
yeah.
tasks, 15 minutes on, 15 minutes off. That's usually what I recommend if they're really young. And then when I say go outside, I say make sure you hang out with some friends every day for, an hour. Make sure in the winter when you can't go outside, make sure you sign up for gymnastics, for swimming, for karate,
Mhm.
for indoor soccer, and then in the summer do outdoor soccer, ball hockey, blah 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 blah. I'm literally giving parents like throwing them a billion
Yeah,
bones just to be like just sign them up for something so that they're busy for an hour or two.
yeah,
That'll just get them off screens, off reading, and socializing with other people and getting their eyes to just fixate somewhere else,
yes,
and rather than just saying, "Go outside."
yeah.
So giving them, like,
Like,
real
do
stuff
what
to do.
outside? What do you
Yeah, like, do
like
what? Kids aren't gonna go outside anymore. So in this book, it does a great job explaining how more so in older patients, like, when we get, like, adult onset myopia as well, we've done a great job explaining to patients that 20/20 vision is perfection.
Mhm.
And when we talked in our refraction episode about how a lot of people come in, they're scared for the one or two refraction because they
Yeah,
don't want to mess up their prescription and get blurry vision.
yeah,
Most of the time, those are also the myopes because
yeah.
we have now set this, it's not a beauty standard, but it's a vision standard that
Mhm.
if you come out of your eye exam without perfect 20/20 vision, something is wrong with your eyes.
Yeah.
Like, why do you not have 20/20 vision? Something is wrong with you. And so
Mhm.
obviously when you go to the eye exam, like everyone's mindset is, "Oh my god, I need to see sharp, clear,
Yeah,
clear, clear." And then we're also trained to prescribe that way. So
yeah,
I think the hard part is like anytime we see kids too, we're
yeah,
just automatically like trained to make sure they have 20/20 vision.
yeah, yeah,
Children do not need to function with 20/20
yeah,
vision unless they are complaining that they cannot see something in their environment every day. And I'm
yeah.
not saying when the parent says, "Oh, little Timmy was in the car and I asked him if he could see the airplane and he couldn't see the airplane." Stop testing your child. That doesn't matter. It does not matter. If
Yeah,
they are in daycare, I need them to be able to see the daycare room. How big is it? What are they focusing on? Playing with toys? Cool. 20/50 vision? Great.
yeah,
Go play, little Timmy. I don't care. So even if he was a -2,
yeah,
I'm not going to correct for a -2 because he does not need more than 20/40 vision.
right.
And then once they're in the classroom setting, same thing. Kids will complain that, they can't see the classroom board and they have sat in the front and in the middle and they're still struggling. If that kid's a -2 or a 2.5 or even a -1, I will prescribe some level of minus because I need them to be able to function.
Mhm,
But am I going to prescribe them a sharp, clear, perfect 20/20 vision? No, you
mhm,
don't need to.
mhm.
When they're 16 and older, I get a little stingy and I do prescribe them perfect 20/20 vision, no matter what minus it is for driving. And,
Yeah,
I am always like, these are your driving glasses. They're stronger than your everyday glasses, but you know what? You're in the car, it's for safety, throw them on. And ODs don't, yeah, pick up on that. Like, even and that's why all these cases on Instagram are like, 5 to, like, 8-year-old kids that have -4 astigmatism or -2 or -0.5, and when you just give them, something to relieve that near stress
yeah,
from, what they're doing every day, that myopia pretty much goes away, or they can be corrected for 1/4 of what
mhm.
you were measuring in the refractive error.
Yeah, yeah,
And yeah, that's kind of how I approach myopia or how, kind of the mindset that I've been learning about. Like myopia is more psychological and behavioral than medical. And this whole
Mhm.
axial length and atropine and we need this multifocal lens. It's great effective treatment and it works,
Mhm.
but it's just like medication. Medication will work too. Medication will bring down your blood sugar. It'll bring down your blood pressure. But why is the body not fixing itself once you've brought down that blood pressure? Why is it still going back up if you remove the medication? You haven't taught the body how to readjust itself, how to rebalance itself, reorient itself. And so the condition is always going to be there underlying. And
Right.
anyone listening to this episode, like I still support myopia control the way, like, all the options that are out there. I even offer those options in my own practice if a patient wants them. But ask yourself, why are your patients still progressing then?
Mhm.
Because all the studies show that these lenses and these lens treatments are effective in slowing myopia progression. Well, if it's still progressing, is it really working?
Mhm.
So what else is missing? Something is missing. If you're giving, a MyoSmart lens or a Stellus lens or a MySight Cooper Vision lenses, if they're still progressing, obviously something did not change that their eyes still want to elongate. They're still
Yeah.
adapting to stress. And
Yeah.
that stress you haven't removed at all.
Yes.
Yeah.
Yes. And I think that's one of the hard parts about myopia management. I know quite a few of the lectures I've been to about it. It's like, well, this is not a guarantee to, stop or even slowly progress things. It can still continue to progress. But then some of these patients pay quite a
Mhm.
bit
Mhm.
of money, even out of pocket, because
Mhm.
insurance, doesn't always fully cover some of these options.
Yeah.
That's where it becomes a little bit like, how do you explain that part to a child's parent? Like, okay, yeah, your kid's a -3 now. We're going to try all these different treatments. Not
Yeah.
sure if it's 100% going to work, but you almost have to pay, $500 to
Thousands,
1,000 to
thousands
get
of
these.
dollars. Yep.
Yeah. So, I mean, yeah, that is a difficult part.
Mhm.
But I was gonna ask you, like, if we can get into more detail of what kind of lens treatments
Mhm.
you would do, like, specifically. I
Yeah.
know we kinda talked about the plus lenses, the anti-fatigue, but, like,
Mhm.
maybe
How
you
do
could
you
get into,
apply
like,
it?
yeah, like, getting into more specific details about that.
The concept of low powered plus lenses or microprisms, these are stress relieving lenses. So, if you tie that together, if we know that, myopia is a symptom of near stress, we can prescribe certain lenses in a certain way or do vision therapy because vision therapy will always, change a patient's behavior, increase peripheral awareness, relaxation, improve accommodation, all that stuff, right? But let's say vision therapy is out of the question because, yeah, primary care ODs are not going to offer that. If we can offer lenses that reduce visual stress, then we're hoping that the myopia and the progression would stop because the
Mhm,
eye is not stressed anymore. And
mhm,
obviously, this isn't also 100% effective because, again,
mhm,
I think with any myopia treatment, if they're still progressing, most likely that patient just hasn't really changed their behaviors and their internal stress levels, right? So, I mean,
right.
yeah, we can only help so much. And then the rest is up to the patient to change or to stay the same, right? Cover test is a huge one that you would want to do
Mhm,
all the time. Let's say you have the distance RX you want to prescribe for the patient in your myopia control option. If you do a cover test on them at near and they are a ortho with no movement or any ESO posture,
mhm,
they're still under stress. Their eyes
mhm,
are over converging for looking at things up close. You're going to get that stress response again. So that distance RX is a no-no for full-time wear. They can do it for far if if that's the best RX for them, but for near, they need something way less. They need a bit more
mhm.
plus.
Okay.
How much plus? Honestly, in a primary care setting, just take a plus 0.5 and a 1.0 flipper. Throw those on top of the distance RX and repeat the cover test. Get something that's at least closer to a low exophoria. 4 to 6
Okay.
prism diopters would be great. If they're an ESO and with your, you're giving them +1 and they became like ortho and you add more plus and it doesn't change, just go for the ortho, go for the +1, just do it. Eventually that system will slowly start to calm down. If you get a large exo, they're not likely going to progress too quickly compared to the ESOs, but
Yeah.
the exo is basically another condition of near stress. So you're
Mhm.
you're basically confirming this patient is under stress, that exo is way too large,
You're
and
just
that
flipping
myopia.
lenses. You're like, "Why are you stressed
Yeah,
out?" I
why are
realize.
you stressed? But again, large exophorias also come with underlying accommodative issues,
Uh,
right? And so
yeah.
again, if you put those plus lenses in front and that exo posture is improving, their NPC is getting better, again, you're balancing out their binocular accommodative system. Their eyes are more comfortable looking at things up
Mhm.
close. Prescribe the plus and make
Yeah.
sure they're switching their lenses for near and far or add it in a bifocal, right?
Okay. So you're saying like separate, possibly separate lenses for distance and near,
Yeah.
or if they want the one, yeah, the
Yeah. And I'll
bifocal versus an anti-fatigue.
But, like, honestly, that's patient preference and doctor
Okay.
preference. I mean, it's up to you. I was never comfortable prescribing bifocals when I first graduated because I never did that for kids, and,
Mhm.
I didn't remember the requirements and how to write it in the prescription. But, I will say a bifocal is more effective in the young kiddos because they don't know where the hell to move their eyes, and they're gonna look in the wrong spots in a PAL or an anti-fatigue, and there's way too much distortion in that lens. Their vision is
Right.
still developing. I don't want any distortions.
Yes. I see. Yeah.
Bifocal is clean, it's easy. The
Right.
seg height is right there, so you know exactly where their eyes are kind of fixating at, whether they're using it or not, so that you can
Mhm.
adjust the lens measurements. I find an and you know what? I'm not gonna lie, the teenagers right now are really screwing me up for anti-fatigues. Did you notice that they're all wearing their glasses down at their friggin' nostrils? Oh my god, it is so annoying because their anti-fatigue lens is, like, by their lip, and I'm like, "You're not using this." And they're
What
just
do you
like,
mean?
"Yeah,
Like
but
it's
it
a
looks
trend
cute."
to
It's a
bring down your
trend.
glass?
Oh, 100%. It's
Oh.
a trend. They have, like, the librarian, like, the glasses are, like, just in the like, their nose pads are just above their nostrils.
Oh, I didn't know about
Yeah.
this.
Yeah, it's really
Yeah.
annoying. It's pissing me off actually, but whatever. It'll go away.
So for me, like I'm already trying to do a lot of that stuff
Mhm.
in practice, especially the cover test, the NPC, NRA, PRA,
Mhm.
especially, with the 7, 8 year olds, 10 year olds. Um, and yeah, I mean, I agree with what you're saying. Like I try to implement all of that and see how again, I'm not I the bifocal for me I've noticed is really hard to convince
Mhm.
parents to get that because they're like, I don't want the line
Mhm.
lenses for my kid. And then anti-fatigue doesn't always give you that
Yeah, it doesn't give you
bottom
the
boost
exact
that
boost
you
you need.
want.
Yeah.
So I don't know. Sometimes I'm kind of like, okay, well, let's do separate lenses. And then the parents are like, well, I'm not going to do multiple
Mm-mm.
pairs. So I'm just going
Yeah.
to do the
No.
distance ones because that's what they need. So I find that a bit of an obstacle when I'm trying to prescribe what I want. And then
Yeah.
I'm like, I can't like fully do what I want and see how I'm
Yeah.
following up with these kids.
And I always tell the parents like, "Listen, I know bifocals sound like they're for old grandpas, but the bifocal is therapy. This is a therapy. This is
Yeah.
not corrective. I'm not giving them glasses for them to see better. I am
Hmm.
giving them glasses for them to function better. I'm going to follow up with them every, 2 to 4 months. And then I'm going to change those lenses when they
Hmm.
get better.
Hmm.
And if they don't get better, then we're gonna keep doing it, and then we're gonna add more stuff. Like, okay, then you can do your combo treatments. You can
Yeah.
then add your atropine. You can then switch them out from a bifocal to, a more specialty design lens. But I guarantee you, if you give it a shot, it will definitely work for most patients. And when the parents know that it's a therapy, they're usually more on board because I will also say, I know, like you don't want to line bifocal. Round is definitely a great option because you really cannot see the line with
Mhm,
a round bifocal. So that's a
mhm.
great option to offer parents. And also, I'm giving line or round bifocals. For me personally, I'm giving them to kids that are like 8 and younger. Because I find
Okay.
that up to grade 2, kids don't really know what the hell's going on. Like, you have glasses, I don't care. What
Yeah.
snack do you have for lunch? Let me eat it. And then when they're in 3rd grade, they're starting
Yeah.
to be more independent, they're starting to,
Yeah.
ask more questions. So by, 9 to 10 years old, I tend to switch them out to an anti-fatigue or a
Ah,
round
okay.
bifocal or single vision, depending on if they even need a
What is
distance
yeah.
RX or not. So it's
Yeah.
really it's your comfort level, but, I skipped this actually, I guess. The purpose of prescribing plus lenses for myopia or microprisms is that you're relieving that stress on
Mhm,
not just the binocular and accommodative system, but there have been studies way back when, but there have been studies that show low plus lenses, like of about plus zero point 0.5,
mhm.
improve your breathing, improve your posture. The plus lenses naturally with optics make objects look larger and farther away from you. So your eyes are now artificially believing that this object is farther away from me. I don't have to converge as much. I
Yeah.
don't have to accommodate as much. My back doesn't have to be as slouched. My shoulders don't have to be so tight. I can start breathing again because now I can comfortably read something. Low plus lenses are literally changing your posture and behavior.
Yeah.
What are you doing with minus lenses when you are giving minus to your myope? You are making objects look smaller and more central, and
Mhm.
you are making that patient converge and accommodate more to see that small object in the center of their vision. Now, I'm saying that like if it's a dramatic change, it's not. It's small, but that's a small change you're making them experience every day because you're making them wear minus lenses full time.
And this is more you're saying, like, up close, like, at near
Up
versus
close
distance?
and even distance. Like if
Mm.
you correct someone at distance and you give them full myopic correction, you're still doing the same thing. So that's where the concept of low plus lenses can be a great myopia treatment option for those patients that are showing all these characteristics, of they do not know how to handle stress and they are very stressed. There's a lot of case example like, there's so many kids that I've had with that. There's so many case examples, but I am creating an actual detailed 2-hour lecture for this stuff with case
Oh,
examples and everything, and, so that's my goal is to have that out by 2025, because
nice.
I wanna see if I can get a CE approved, that would be really nice,
Yeah.
um, but yeah, there's a lot more detail to all of this, but I think this is a good
Yes.
gear grinder
Yes, I would
for
say I
primary care.
know for some of our listeners, this might be like, "What are you
What
guys
the hell?
talking about?" But yes, that it's just what we're talking about is very generalized. It's quite broad. There's a lot more
Mhm.
backstory and detail to a lot of what we're talking about.
Yeah.
Um,
Yeah.
so this is just not like something where it's like, "Oh, I'm just gonna hop on this and see what happens." No, like there's a lot of courses and everything on this that
Yeah.
kind of again makes you think about things a little bit differently than what we've always learned in school.
Yeah.
So,
This is a really good concept. I really encourage new grads coming out and just, people that have been like us that have been practicing for, within like 5 years. School teaches us a lot of things, but it also doesn't teach us a lot of things, and
yeah.
there's so much more out there when it comes to prescribing, especially for kids. Kids are
Yeah.
such sponges, they're gonna absorb whatever you prescribe them, and so just always go less. Myopia is like any other medical condition where there's other underlying factors, there's psychological factors, there's behavioral issues, there's, binocular vision issues. Instead of always jumping to offering parents and patients the most expensive intense treatment option and treatment plan. I know that they are effective and it helps business as well. there
Yeah,
are easier
of course, yeah.
options. And these are great options for people like who work in rural practices and rural areas. There's always ODs saying, I can't recommend vision therapy to my patients because it's just not that demographic. It's a low income area, it's a rural area. Well, most likely you're probably not offering these
Yeah,
myopia control treatment options either. You're probably not, offering MySight and Stellest and because they're expensive.
yeah,
And so this is a great way to just start practicing myopia control with your everyday lenses, your everyday glasses, and nothing else.
yeah.
And education, free education to the patient on how to change their habits and their behaviors and their stress levels.
Mhm.
Like it's such a nice way to start. And when you start seeing the results, you honestly don't need to rely so much on all the other treatment options. Like I haven't used any of them on a single patient since I've graduated. Like I just
Mhm.
haven't. And I get yelled at by my practice consultant because my practice consultant wants me to start prescribing all these things so that I can make a nice profit on my business. And I totally get that too. Like I have bills to pay and I would love to have a higher profit by offering these other effective treatment options. But if I have an effective treatment option that costs the patient less and the parents appreciate that because they're already going through so much shit with these little kids,
Yeah.
trust me, you'll have that patient for life. Like
Yeah,
yeah, those people will stay with you forever.
yeah.
So yeah.
I mean, yeah, and it's nice to have other treatment options that are maybe not as have that hefty price tag on there just with the economy and
Mhm.
everything. We've all heard of
Yeah.
inflation. So
Yeah.
it's nice. But yeah, I mean, again, I've obviously used some of these myopia control methods like the MyoSmart Stellist, but I
Mhm.
will say I have done these options you've talked about, like with the plus lenses, especially the
Mhm.
low plus lenses with these minus zero point 0.5 or minus 0.75 kids.
Mhm.
And yes, it has worked for me. So
Yeah.
I'm really, again, like I think with optometry,
She's a
sometimes when you're,
believer.
yeah, no, but I'm just saying sometimes when I took this course, that course
Mhm.
we were just talking about, a lot of the people in that course were very similar to me. They were just all in primary care, and we were all kind of talking about why we were taking that course. And I think sometimes in optometry, you just kind of get into this redundant method of doing the same thing over and over again. But
Mhm.
then eventually over time, you're kind of like, am I really helping people? Or am I really like
Mhm.
prescribing what I'm supposed to be? And you
Yeah.
just start thinking about things and you're like, I don't really know, like things are becoming worse or, if I'm really actually helping. And then when you take this course, it again makes you think about things differently and how
Yeah.
you're prescribing things differently. And once I started prescribing these like baby myopes a little bit differently,
Mhm.
I was like, "Oh, okay." And it's worked, like, what I prescribed, like, these low plus lenses. I was like, "Oh my god," like, I didn't put them in that -1 lens. I feel like I
Yeah.
didn't overcorrect them, and now they're not on this trajectory of, like, becoming
Yeah.
this moderate myope.
Yeah.
So I will vouch for that. It has worked for me. As I said, for the -2, I'm not that confident yet to be like, nope, we're gonna slap on this like, plus lens. I don't feel like I'm specialized enough to do that. However, I will say if I have a kid that is almost like a -4 or more, -5, I will talk to the parent about seeing a behavioral optometrist
Mhm.
because if they don't want to do all these like more expensive myopia control treatments, I'll talk about this other option
Yeah.
that they have.
Yeah. Actually, I'm gonna add on to that. Like last tip for primary care ODs, when you have those high myopes that are young, I strongly recommend adding a referral to VT on top of your treatment options because your
Mhm.
treatment options, your lens options are going to help to, slow down that progression. But there are underlying behavioral issues in that person, right? Like that person doesn't know how to manage their stress. They don't know how to manage their binocular accommodative system, regardless of what lenses you give them. Vision therapy is not just to do flippers and make your accommodation stronger. Vision therapy gives you feedback on how your eyes are working together and how they should work together. It works on breathing, balance, posture. It works on all these things. So you can always add a referral to a VT doc as part of your co-management.
Yeah.
And you can let the VT docs know that, because trust me, VT docs also do not enjoy primary care. We do not want to steal your patients. We want your patient to come in once a week, do the therapy, and ship them back off to you for their routine eye care. So it's a great option to add that in your treatment plan, because I'm sure a lot of you have myopia control plans, like, with the papers and the contracts, and here's the management fee and all the stuff we're going to do. For the high ones, you can definitely just add, we're also going to send you to a vision therapy doc for secondary treatment, and then we're still going to work on your primary treatment. Hopefully that helps a lot of you guys. I know, yeah, like Deepon said, it's vague, but I am really working on a lecture that would explain this more. There are already amazing BVVT docs out there lecturing on these things at vision therapy conferences, BV conferences. If you read articles from the OEP, COVD,
Mhm.
you're gonna find all this information. But yeah, it takes time to find it. It took me 5 years to find it. So like, good luck. Yeah. So let us know what you guys thought about this episode. You can always send us messages through Instagram. Yeah, let us know how it was.
Thanks for listening to Four Eyes, the podcast series brought to you by Young OD Connect. Be sure to subscribe and follow us on Instagram or YouTube at Four Eyes Optom for more content. We'll see you guys next time. Bye.
Bye.